Hi guys, and welcome back to Stat Dose podcast. Today we're doing another turbo dose, and we're going to do a quick introduction to the approach to delirium. So hopefully this will give you a standardized approach and some of our thoughts as to how to manage this patient both in the simulation and in the clinical environment. So Matt, delirium's it's not necessarily a diagnosis, is it? What do you think in terms of a delirium? How would you sort of define it?
It's a feature, it's a symptom, it's not a diagnosis. And it's an acute, transient, reversible confusional state. I think those are the key things. It's separate from dementia, which is not acute, not transient, not reversible, but is a confusional state. And there's often an underlying organic cause that triggers the delirium. But typically there's three sort of broad types when we're approaching patients with delirium. So there's the hyperactive delirium. You see these patients, they're the agitated, aggressive patients. They might wander around their clinical environment. There's often hallmarks of delusions or hallucinations and things. There's the hypoactive patient, which is often more difficult to spot. So they're sort of lethargic. They might be sleeping excessively. They're sort of a bit inattentive. Sort of normal tasks take quite a long period of time. I remember one patient I saw recently, his wife reported that it was taking him a long time to make a cup of tea, which is one of the first sort of signs that something wasn't quite right, which I thought was interesting. And then the third type of delirium is mixed, where you get a combination of both the hyperactive and hypoactive.
So thinking about the assessment, we actually want to find out what the root cause is in order to manage it. As always, we're going to talk about this in terms of an A to E approach. But I think in the context of delirious patients, particularly those who are hyperactive, it can be quite difficult to assess these individuals, and they may actually be quite resistant to examination, and actually getting hands-on with them can be a little bit more difficult. So it's just important to remember when we're sort of talking through this now, this is in the context of a patient who can be quite difficult to manage. But we do try and do an A to E as much as possible. Sometimes that's about doing it sort of hands off. And one of the key things to do at this point is to try, if you can, to reassure, build rapport, utilize family members and other members of staff to keep the patient calm if possible. Those individuals are also really, really helpful, family members, etc., at getting a history, because these patients are typically poor historians, again, due to their cognitive impairment. So it's about getting that collateral. Matt, do you sort of use any other sort of scores or anything like that?
The main one that I like to use is the mini ANTS, so the 4 questions, sometimes abbreviated to PADI. So that's place, age, date of birth, and year. So you just ask the patient, do you know where you are? How old are you? What's your date of birth? And what year are we in at the moment? And then you get a score out of 4, and that's just a very quick, easy, useful objective measure of cognition.
And so, sort of moving on. That primary survey is focused on trying to find evidence of what is causing that problem. So one of the biggest things that we want to look at is there a source of infection? And the way that I do that is by going through the body systems in my mind. So, looking at skin, looking at chest, looking at abdomen, looking at GI, GU, and on and on from there, looking for signs and symptoms of infection. One of the, I think, traps that we fall into here in practice, where we're not thinking outside the box, and we're not sort of holistically managing this, is we'll often sort of, almost go, is there a cough? No. Any burning when they pee? No. Oh, I'm a bit stuck now. As though those are the two, they are very common, but the two only sources of infection. I think we just need to be really careful there and really examine thoroughly. So look at that's what exposure is all about, isn't it? Expose the legs, look for cellulitis, look for wounds or pressure ulcers that may be infected. Matt, what other sort of things would you be looking for in a delirious patient in terms of sort of investigations?
So we move on to blood tests. A few key things that we're looking for. So hematology-wise, we want to do a full blood count. That will help look for infection markers, so white cells. Also check for anemia, which is important. Baseline coagulations always help. Biochemistry-wise, want to do some use and ease. That will see if there's an acute kidney injury. It will also check the sodium, so hyponatremia can cause you to be delirious. Bone profile, particularly looking at calcium, so high or low calcium can cause delirium as well. Thyroid function, again, high or low can cause delirium. Hematinics, there's actually B12, folate and ferritin. Deficiencies here can also cause delirium. And then the glucose, obviously hypoglycemia can cause confusion. And then other blood tests. So if you think the patient's septic, you're going to want some blood cultures and a blood gas as well to look for the lactate and also give you that quick glucose. Other things, moving away from blood tests, one of the things that we often get sort of asked about is CT heads. It's not required for all delirium. CT heads will only show large ischemic strokes. They'll show intracranial bleeds. They'll show space occupying lesions or raised intracranial pressure. There are many other causes of delirium as opposed to those big four. But it's important when you're assessing that patient with your A to E approach, with your examination, that you look for any evidence of subtle head injury, especially if the patient is on an anticoagulant.
If I'm thinking from a primary care perspective, particularly, one of the things that we get called about is the ability to undertake urinalysis, urine dips. Mm. Undertaking a urine dip in this population is probably not going to help you significantly because there's such a high prevalence of asymptomatic bacteria. So what we might find here is a sort of positive urine dip, treat for a UTI that's not actually an infection. And this is where we get problems because actually we're misdiagnosing these patients. And on top of that, we're giving large amounts of sort of urinary antibiotic. We need to only really be thinking about urinary tract infection when there are actual clinical findings suggestive of a UTI. So suprapubic tenderness and lower urinary tract symptoms such as dysuria, frequency, hematuria, etc. Quite often we get that clinical handover of, oh, the patient smells of urine or there's an offensive smell, but that's not an indication of urinary tract infection.
So moving on then, we'll just cover some of the key causes for delirium. I think we'll just list off a few here. There's obviously quite a lot, and there's plenty of sort of acronyms and things out there that you can use. So just find one that works for you. So some of the more common ones here, as we've already alluded to throughout this podcast. So infection or sepsis, obviously quite a common cause, as we discussed. Drugs, particularly common in the elderly. So there's lots of prescribing for most of our elderly patients. Key things to consider would be opiates, sedatives, or missing medications. Recreational drugs as well. So just because you're 80 doesn't mean that you don't partake in recreational drug use. And equally alcohol alongside that, both intoxication and or withdrawal from alcohol is surprisingly common. Other big things we need to consider. So pain, hypoxia and constipation or urinary retention. These are often missed and quite easily reversible. And then certainly when you've got patients who have acute on chronic cognitive impairment, environmental changes. So if you move somebody from a nursing home, for example, to a clinical environment, that may well be enough to trigger some delirium. The final sort of common cause of delirium that we see is something like a stroke or an intracranial bleed.
The other very frequent time that you will see delirium and or sort of agitation is in your terminal end of life palliative care patients. Very commonly, we might be called to assess and manage a patient with this and with the aim of giving a midazolam, a rescue dose or something like that. But actually what we have to ensure is that actually that patient isn't in urinary retention because there's no amount of midazolam that's going to help that. And we just need to be really, really cognizant that this might be also an exacerbation of breakthrough pain and any other of the signs and symptoms that we've talked about. So it really is a sort of diagnosis of exclusion to simply say that this is sort of end of life delirium.
So talking about the management then, obviously it depends on the likely underlying cause. So obviously, treat that once you've identified what it is. But I think from my perspective, I'd always advocate having a low threshold for treating sepsis. Essentially, if a patient is delirious secondary to an infection, that implies that the sepsis is causing end organ injury, so therefore is probably more severe than observations might necessarily suggest. So if you do think there is infection or sepsis on board, be aggressive with your sepsis 6 early on. But otherwise, general sort of supportive management that we've sort of discussed already includes make sure you're orientating the patient to time and place, reassure them as best as possible, make sure you're clear with your communications, giving regular explanations for what you're doing and why you're doing it. Always remember checking for hearing aids and glasses, and try to consider useful sort of environmental things like having a visible clock or making sure they've got a watch on, involving the family where able. Lighting and temperature and things like that are good, and try and keep it a low noise environment.
So finally, a presentation that junior doctors are very commonly called to, where the ward staff are asking and assess a patient for sedation. And unfortunately, this is often asked for those patients who are causing a bit of a nuisance, confusion, calling out, wandering, etc. And sedation is quite a risky undertaking, even just providing sort of oral lorazepam or something like that. It is quite risky. It's a CNS depressant. You're prescribing for often elderly comorbid patients who have low thresholds for this sort of thing, and probably not actually helping why they're in hospital in the first place. And sedatives can actually worsen delirium or sort of mask the underlying cause as to why they're in this position in the first place. We need to use the least restrictive method. What do you think about that, Matt?
Completely agree. I think, as you said, the least restrictive method is that's a key sort of phrase. And there's also the key legal element to it as well. We need to make sure that you're practicing, within the boundaries of the law. So, as you say, it's a very common call out for junior doctors. Can you come and sedate this patient? They're wandering around the ward, and actually, is the patient on a dose? Have you deprived them of their liberty so much so that you're going to chemically sedate them? Have you considered things like the Mental Capacity Act? I'd always advocate, certainly for junior doctors, checking your local guidelines, discussing with your seniors if you're considering going down that route.
So that's all for us today in terms of general approach to delirium. We've talked about the sort of overview and classification of delirium. We've spoken about the assessment and using an investigative approach to this, making sure that you're trying to do an A to E as much as possible, but appreciating that this may need to be a little bit more hands-off, utilising your family members, utilising clinicians who've been with the patient, and then considering those really important investigations that may lead you further down the line to getting a diagnosis that is causing this delirium.